Hello, I'm Dr. Takou, consultant histopathologist at the Royal Hallamshire Hospital in Sheffield, and today we will discuss about the renal transplants pathology, the band classification and its applications to the assessment of the renal transplant biopsies, and we will go through briefly the commonest causes of acute and chronic graft dysfunction. Based on the WHO data and the activity from 104 countries, it appears that more than 70,000 renal transplants are performed worldwide annually. And although there has been an improvement in the survival over the last 2 decades due to the introduction of a new class of immunosuppressive agents, the long-term loss of the grafts, unfortunately, has little changed. Despite the recent introduction of several modern diagnostic procedures, the renal biopsy still remains the gold standard in the diagnosis of graft dysfunction causes. It is an essential tool to establish a tissue diagnosis, to modify the therapy, and also to establish prognostic factors that may affect the long-term graft survival. Most renal transplant biopsies are taken because of impaired renal excretory function and therefore should be regarded as urgent specimens and should be processed with the shortest possible delay. This is the reason why in most centers nowadays a same-day rapid processing of formalin-fixed tissue technique exists. In regards to the frozen section technique on renal transplant cases, experience has shown that this is a much less reliable technique and should be avoided as it may lead to diagnostic errors. Ideally, 2 cores of renal cortex containing at least 10 glomeruli and 2 arteries should be received. Most of this tissue is processed for light microscopy, however in some centers a small fragment of the core is not frozen for immunofluorescence studies, whilst in other centers immunohistochemical peroxidase studies are preferred. No tissue should be sampled for electron microscopy unless there is clinical suspicion of de novo recurrent primary disease or of chronic transplant glomerulopathy or chronic antibody-mediated rejection. We prepare 4 sections stained with the traditional hematoxylin and eosin stain, but we also prepare sections stained with several special stains. So for example, a PAS and an MST silver stain highlight the basement membranes. Therefore, it is easier for the pathologist to interpret any changes in the glomerular or tubular basement membranes. A MILAB or an EVG stain will highlight the vascular changes, whereas the trichromatin stain will reveal the degree of background interstitial fibrosis. Typical amyloid stains have also been introduced into our routine special stain pattern, as these are extremely helpful in highlighting tiny amyloid deposits in the mesangium of the glomerular tufts. Immunohistochemical studies for T cells, the C4D component of the complement, and also CMV and polyoma viruses are also performed routinely. Each set of these stains should be carefully examined and all the different components are assessed. You need to remember that medulla is inadequate to exclude rejection. Likewise, subcapsular renal cortex often is not representative of the changes that may exist in the deeper layers of the cortex. This is a nice example here where you can see 2 long cores of renal cortex that contain glomerular structures, but also vascular structures and of course numerous cortical tubules. As opposed to this sample here, where half of the core comprises fibrous capsule and the other half subcapsular renal cortex, where we normally have a degree of interstitial scarring and of course mononuclear cells aggregates. The lesions in the renal allografts that we will focus on today can be classified into the three following categories: immunologic rejection, either humoral, cellular, or chronic rejection; non-rejection injury; and of course the category of recurrent primary or de novo renal disease. Important pieces of information the pathologist needs on the request form are the date of the transplantation and the gender of the patient. And the single most important piece of information that the pathologist must communicate to the clinicians is whether there is clinically significant active or chronic disease or any other type of pathology that may require immediate treatment. Now, several scoring systems have been proposed over the years, with the two most common, most well-known being the Banff classification and the CCTT system. Nowadays, the most widely used scheme is the Banff classification, which was introduced by Solas et al. In 1993 in an attempt to reach a consensus acceptable for routine diagnostic use, but also patient allocation for drug trials. The Banff classification has undergone several modifications and revisions over the last years, with the latest version being the revised Banff 2013 classification that includes updates in regards of antibody-mediated rejection scoring in renal allografts. Banff recognizes three major categories of acute cellular rejection. Type 1, which refers to disease that is confined within the tubular interstitial component. Type 2, which in addition shows vascular changes such as endothelialitis or endotiritis. And type 3, that displays transmural arteritis and/or arterial fibrinal type necrosis. The difficulty with acute cellular rejection is that there is a huge variation histologically from no cellular infiltrate to marked widespread inflammation of the cortex, which makes it extremely difficult for the pathologist to decide between significant immunologic response that causes renal dysfunction, therefore requires treatment, and clinically insignificant cellular infiltrate. This is the reason why the borderline suspicious category in Banff and its clinical implications still remains nowadays a grey debatable area. Now, when we're looking at an acute cellular rejection case, histologically, according to Banff, we have to score 4 different structures and components. And these are the degree of interstitial mononuclear infiltration, the presence and severity of tubulitis, whether there is vascular involvement and how severe that is by the inflammatory population, and the presence of mononuclear cells in the glomerular capillaries. When an additional or a concurrent element of humoral rejection is suspected, 2 more elements are scored, and these are the activity in the pertubular capillaries. By activity, we mean the presence and the numbers of the inflammatory luminal cells, and of course the C4D staining. The C4D is a component of the complement activation, which is usually activated in an antibody-mediated rejection. We can detect the C4D status by performing immunoperoxidase studies on paraffin sections from formalin-fixed tissues. Separate scoring for chronic lesions is also available, so when we assess a chronic rejection case, we need to comment in our report on the degree of transplant glomerulopathy, the tubular atrophy, the interstitial fibrosis, and the chronic vascular changes. Banff also identifies and recognizes 3 criteria in order for us to be able to label a case as acute humoral rejection. First of all, we need to have histological evidence of acute tubular injury. Then we need to have evidence of antibody interaction with the tissue, and this is confirmed by peroxidase studies for the C4D antibody. And we also need to have serologic evidence of circulating antibodies to antigens expressed by the donor endothelium. When only 2 out of these 3 criteria are present, then the case is best regarded as suspicious of antibody-mediated rejection. Specimens taken for the investigation of acute graft dysfunction usually reveal one of the 3 following causes: rejection, either cellular or humoral, acute tubular injury or necrosis, and major artery or vein thrombosis. So, a transplanted patient presenting with rise in the serum creatinine, weight gain, fever, or in some cases even tenderness over the grafted kidney, all of these clinical features most likely reflect an acute cellular rejection, which is the most common form of rejection and may happen during the first 6 weeks, but can occur at any time after the transplantation. In a well-established typical case of acute cellular rejection, histologically, we see a brisk infiltrate of activated lympho and monocytes, T cells and macrophages in the interstitium, which is markedly edematous, but also in the tubules. The mechanism behind this is that the recipient cells react to donor alloantigens. In the most severe cases, we may have a similar inflammatory infiltrate involving the arterial intima and the glomeruli, but we also may have signs of injury of the target cells. So, for example, we may see swelling and loss of the endothelial cells or tubular cell apoptosis. You need to remember that histologically, a very early acute cellular rejection may only show an inconspicuous intratubular infiltrate. However, infiltration of mononuclear cells under the arterial or arteriolar endothelium is a really strong indicator that we're probably dealing with an acute cellular rejection of type 3, according to Banff. This cortex in a needle biopsy specimen of kidney was taken 7 days after transplantation in a patient with sudden rise in the creatinine. There is a patchy distribution of a mononuclear infiltrate with lymphocytic aggregates in the interstitium surrounding and involving tubules with areas of established tubulitis. Alternatively, the pattern of inflammation in an acute cellular rejection case may be completely different. For example, in this core here, you can see that there is a sprinkled mononuclear infiltrate throughout the core, with only one occasional lymphocytic aggregate present. Examination and higher magnification revealed foci of tubulitis in this case, and an acute cellular rejection diagnosis was established. Renal transplant biopsy taken 2 months after transplantation into a patient age of 32, with initial satisfactory function but sudden deterioration. You can see here that there is marked edema in the interstitium. All these white pale areas is edematous interstitium, which is accompanied by a mild, chronic mainly inflammatory infiltrate consisting of plasma cells and lymphocytes. The tubular profile in the lower left quadrant of this picture shows invasion and involvement by chronic inflammatory cells that cross the tubular basement membrane and obscure the tubular epithelium, which is acutely injured. This is a very nice example of a typical tubulitis feature. In the more severe cases, we may have tubular profiles which are not involved by inflammation at all, but then again, this adjacent tubule here shows involvement by small lymphocytes that cross the tubular basement membrane and create an artifactual clear halo around their nucleus, which makes them easier to detect by the pathologist. Similar case of severe acute cellular rejection with a heavy mononuclear infiltrate present in the interstitium, and marked severe tubulitis with more than 10 mononuclear cells involving this tubular structure. This is a very nice example here that highlights the importance of the basement membrane special stains. This is a silver stain, which is extremely helpful for the pathologist to identify areas of tubulitis. So the MST stain highlights the tubular basement membrane as an intact, fine, dark black line, highlighting the external border of the tubular profiles. The tubular structure in the center of this picture shows partial dissolution and rupture of the basement membrane, and chronic inflammatory cells crossing through the membrane, invading into the tubular epithelium. This is a very nice example of a focus of tubulitis in an acute cellular rejection case. Higher magnification reveals similar appearances in another case of acute cellular rejection. So this tubular profile here shows ruptured basement membrane at this site and several mononuclear cells entering the profile. If we compare it with the adjacent tubules here, we see clearly that these profiles are not involved by inflammation and they highlight intact, smooth tubular basement membranes. A type 3 acute cellular rejection according to Banff, where you can see here in the center an artery displaying marked wall thickening and also involvement by inflammatory cells. There is also a collection of mononuclear cells underneath the endothelium, and this is what we as pathologists call transmural vasculitis and endarteritis. Similar appearances here with an artery surrounded by collections of mononuclear cells, and its wall is involved and penetrated by these inflammatory cells. Two types of primary antibody-mediated rejection exist, with the hyperacute variant being the most dramatic and rapid one, where we have immediate graft loss at the time of the transplantation due to pre-existing antibodies in the pre-sensitized recipient. This is a rare phenomenon nowadays, and we mostly deal with the conventional variant of the acute antibody-mediated rejection, which may also cause acute and severe graft dysfunction. This type of rejection may happen at any time after the transplantation. It is less responsive to therapy and carries a worse prognosis for the kidney compared to the acute cellular rejection. The histological changes may range from simply acute tubular injury without inflammation at all, through to infiltration of the peritubular capillaries and or glomerular capillaries by neutrophils, to frank necrosis of the arteries in the more severe cases, and may show or may not show C4D deposition in the peritubular capillaries. So this is a nice example of an early antibody-mediated rejection here, where you can see the tubular profiles highlighting a degree of acute tubular injury with loss of nuclei, vacuolar cytoplasm, thin epithelium, but there is no inflammation at all in the background interstitium. You will also notice that there is no interstitial expansion at all in this picture, and the tubules are closely located to each other. Similar appearances here from another area of the same case, where there is only a mild degree of acute tubular injury, but no inflammation in the background. You can imagine our surprise when immunoperoxidase studies were performed on paraffin sections from formalin-fixed tissue, and the C4D antibody revealed strong linear deposition of C4D along the peritubular capillaries, along the endothelium of arteries, but also in the glomerular capillaries. This case was labeled as early acute humoral rejection. Because the early tubular changes can be quite subtle, having no cellular infiltrate, may be completely overlooked histologically, and this is the reason why we introduced immunohistochemical stains for C4D in our everyday routine practice. We know that complement activation is an integral part of the immunological response in AMR. The circulating antibodies in acute humoral rejection are usually to donor HLA class I antigens, although a minority may show only reactivity to class II or non-MHC endothelial antigens. The risk factors include positive cross-match associated with prior sensitization of the recipient. And as the disease evolves and progresses, you can see that in addition to the acute tubular injury, now we have margination of neutrophils and inflammatory cells in the peritubular capillaries. And this is another example of peritubular capillaritis, where the capillaries are dilated and contain several inflammatory cells in their lumens. A similar case here of more severe capillaritis, with these tubular profiles being completely packed with inflammatory cells. In the more severe cases, we may also have vascular lesions, and this is an artery here that shows a collection of mononuclear cells underneath the endothelial lining, which is nearly detached from the underlying wall. A similar case here with loose, thickened intimal containing several inflammatory cells in this artery, and this is a case of acute antibody-mediated rejection. We can also perform immunoperoxidase studies and antibodies for the T lymphocytes, which make it even easier for the pathologist to identify areas of endothelialitis or endarteritis, as seen here in this vascular channel, where you can see the T lymphocytes staining as brown underneath the endothelium. When immunoperoxidase studies for the C4D antibody were performed, there are foci of strong linear C4D deposition along the inflamed peritubular capillaries, and this was not a localized phenomenon, but other areas with similar features were seen in this antibody-mediated rejection case. You need to remember that we may have C4D deposition along the bigger vascular components or even the glomerular capillaries in acute humoral rejection. Cases of concurrent acute cellular and humoral rejection exist in our everyday practice, and this is a nice example here where you can see that there is a brisk mononuclear infiltrate in this tissue with areas of marked tubulitis, and if we examine the tissue in high magnification, we can see that there are also peritubular capillaries that show quite marked activity in their lumens. And when immunoperoxidase studies for the C4D antibody were performed on that case, there was a strong linear C4D deposition along these inflamed peritubular capillaries, and this case was labeled as acute cellular rejection with a concurrent component of humoral rejection. Other non-rejection causes of acute graft dysfunction exist, and these include structural damage of the tubules with evidence of acute tubular injury or acute tubular necrosis, infarction of large vessels, and of course infection. Please remember that these histological criteria are not absolute, and in our everyday practice we have in most cases overlapping appearances. Looking at the non-rejection injury now, preservation injury may result from the kidney becoming anoxic during harvesting or transport. The histological appearances are those of acute tubular necrosis, and there is poor function of the graft initially, which may last for several days if the damage is severe. Prolonged failure to function initially adversely affects the graft survival. So for example, here you can see these tubular profiles which are severely damaged with wide gaps in between the tubular epithelial cells. There is a variation in the nuclear size, with some of the nuclei being more hyperchromatic than others. We also spot some mitotic figures, which is an indication that this case undergoes through the regenerative phase of acute tubular injury. And there's also some cellular debris in the lumen of these tubular profiles. Similar appearances here with acutely badly injured tubules. Now, cyclosporin may also cause toxic associated histological appearances in our biopsies of renal transplants. So there may be widespread fine isometric vacuolation of the tubular cell cytoplasm that results from dilatation of the endoplasmic reticulum seen ultrastructurally. And this is an example of damage that may be reversible by lowering the dose of immunosuppressive drugs. So, for instance, here you can see the tubule in the center of this picture, displaying clear views of the cytoplasm of the tubular epithelial cells, with their nuclei being basally located but more hyperchromatic compared to the adjacent viable, nearly normal tubular structures. And if we examine the tissue in high magnification, we can see that there are several cytoplasmic vacuoles of similar size, and this is a widespread feature affecting all of the tubular profiles in our field. Similar appearances here from a case with cyclosporin toxicity, clear views of the cytoplasmic tubular epithelium. Infarction is another cause of acute graft dysfunction and may be due to thrombosis in a large artery or vein. In this picture here, you can see the thickened and tortuous wall of this artery, whereas its lumen is nearly occluded by a well-formed thrombus. The affected part of the kidney undergoes infarction with hemorrhagic appearances and ischemic type necrosis. The architecture here of the different components is retained, but no viable cells are present. So you can still see the ghosts of the tubular profiles and glomeruli, but no nuclei are present in the cells, and this is an indicator that this tissue is no longer viable. A similar case displaying widespread hemorrhagic appearances and also ischemic type necrosis of an infarcted kidney. The gradual loss of graft function is yet another common problem, with the median graft survival being just up to 10 years. The decline in function may be a sign of chronic rejection that usually affects all of the different components in our tissue, the tubules, the interstitium, the vessels, and the glomeruli, and is usually the result of a slowly progressive process due to persistent and/or recurrent ongoing immunologic activity. So histologically, we may have features in terms of tissue injury, fibrosis, arterial intimal fibrosis, glomerular basement membrane, and peritubular capillary basement membrane duplication. But we also may have features suggestive of activity, such as tubulitis in non-atrophic tubules. This is a nice example of a chronic rejection case where you can see the glomerulus at the center of the field showing mesangial expansion, but also markedly thickened capillary walls. On top of that, there are thick bands of fibrosis accompanied by atrophic tubules and foci of mononuclear cells present here surrounding a completely burnt out, globally scarred tubule. In the more severe cases, we have more dense and severe established fibrosis and collections of mononuclear cells in the background interstitium, the tubular atrophy is more widespreadly allocated, and you can see here that there is an artery in the lower left quadrant of this picture that shows quite marked wall thickening, and its lumen is nearly occluded. The trichrome mason stain helps us to identify the degree of background interstitial scarring. So, for instance, here you can see a few islands of non-atrophic tubules present, but there are quite thick bands of fibrosis running through these areas with atrophic tubules. The glomeruli now, in a chronic rejection case, may develop chronic transplant glomerulopathy, which is defined as duplication or multilayering of the glomerular basement membrane due to repeated or persistent immune injury to the endothelium. This appears as double contours of the glomerular basement membranes on the silver stain. However, please bear in mind that this is not a pathognomonic feature of CTG only. It may be seen with thrombotic microangiopathy, scleroderma, immune complexes, eclampsia, or CNI toxicity. This is how a glomerulus displaying CTG looks like on the traditional hematoxylin stain. You can see the expanded areas in the mesangium, but you can also notice that the capillary walls are markedly thickened. And if we look at the silver stain from this case, we see that there are segments of the tufts that show double contours, double layering of the glomerular basement membranes. As this lesion progresses, it may show more severe appearances of the glomeruli, as in this example here, where we have more than 90% of the tuft involved by double contouring. The characteristic feature of chronic transplant glomerulopathy on electron microscopy is multilamination of the glomerular basement membrane that extends sometimes circumferentially around the capillary lumen, and the endothelium appears to be reactive with loss of fenestration. This is another segment of the capillary wall that shows subendothelial expansion due to new basement membrane material being deposited in a multilayering pattern. Other non-immunologic causes of chronic graft dysfunction are infections, cyclosporine chronic nephrotoxicity, renal artery stenosis, and recurrent or de novo glomerulopathy. Cytomegalovirus damages the renal transplant as a result of primary infection, and this occurs in a seronegative recipient receiving either infected blood or transplanted organ. It may also result of reactivation of a latent infection or as reinfection, which occurs when a seropositive recipient receives an infected organ bearing a different strain of the virus. The intensity of the immunosuppression, and in particular the use of anti-lymphocyte antibodies, is directly relevant to the development of CMV involvement. Two patterns may be seen histologically. The first one is a glomerulopathy with endothelial damage and necrosis, along with fibrillar glomerular deposits and a mononuclear infiltrate present. There are no characteristic CMV viral inclusions present in these cases, and the mechanism is thought to be immunological. The second pattern of injury, which is rarely seen today, comprises of CMV viral inclusions in the endothelial cells of the glomeruli, of the peritubular capillaries, or even within the nuclei of the tubular cells. These changes indicate a direct viral infection in the kidney. For instance, here, in this case of CMV infection, you can see that the tubule shows strange nuclear profiles and is involved by small lymphocytes that cross through the tubular basement membrane. Immunoperoxidase studies performed for this CMV antibody revealed strong nuclear staining in the affected tubular epithelial cells. Another common virus that may affect the transplanted kidneys is polyomavirus. The infected cells display characteristic intranuclear inclusions. Usually the tubular epithelial cells are affected on a renal biopsy, and we can highlight them immunohistochemically by performing the SV40 antibody. The tubule in the center of this picture shows a darker hyperchromatic nucleus that most likely includes a viral inclusion. And when we looked at other areas of the same case, we noticed there were similar tubular profiles with appearances of darker and enlarged nuclei of the tubular epithelial cells. Immunoperoxidase studies were performed for the SV40 antibody, and these revealed strong, widespread nuclear staining along the affected tubular epithelial cells. You need to bear in mind that the interstitial nephritis, which sometimes accompanies the viral infections, is morphologically similar to that seen in cellular rejection, complicating even more the differential diagnosis for the pathologist. The intranuclear inclusions in the tubular epithelial cells are the diagnostic discriminator. However, nowadays this is a rare phenomenon. Patients treated with tacrolimus and MMF are particularly susceptible to virus damage. Another virus that may affect the grafts is the Epstein-Barr virus, which induces B-cell proliferation and transformation. Chronic immunosuppression, particularly using tacrolimus and mycophenolate, may give rise to post-transplant lymphoproliferative diseases. The T cells are suppressed and thought to remove a restraining influence on the Epstein-Barr virus, which affects the B cells. Withdrawal of the immunosuppressive therapy is the appropriate treatment at an early stage. Cyclosporin may also cause injury in the vascular channels of the graft and may result in delayed or chronic graft dysfunction. You can see here in the picture on the left, this is an artery that shows nodular sclerosis and hyalinosis on the PAS stain, which is a strong indicator that we are dealing with probably CNI chronic toxicity in this old graft. In the picture on the right, you can see a burnt out globally sclerosed glomerulus with areas of nodular sclerosis involving the vascular pole and the vessel that feed this glomerulus. A similar case of CNI toxicity with a globally scarred glomerulus and an arteriole showing nodular hyalinosis. A recurrent primary or de novo glomerulopathy may also be a cause of chronic graft dysfunction. These lesions are classified as immunological, metabolic, or of a known etiology. The histological appearances are similar to the ones that we can see when we assess native kidney biopsies. So, for example, in an IgA nephropathy, recurrent glomerular nephropathy, you can see here that there are areas of mesangial proliferation with segmental sclerosis. In a membranous case, we have diffuse spiky appearances present on the silver stain on the external surface of the glomerular basement membranes. Amyloidosis may also recur, and this is the Congo red stain that shows the typical salmon red looking glomeruli due to amyloid deposits in their tufts. And of course, diabetes, recurrent diabetes with nodular glomerular sclerosis. In conclusion, and messages to take home are the following. Yes, histology has limitations, and your expectations for the pathologist should be reasonable. Clinical pathological correlation is crucial for the pathologist to be able to establish a diagnosis. You need to remember that the histological appearances in the common everyday practice are usually overlapping. For example, a single histological feature such as tubular atrophy may result from several different causes. You also need to remember that we may be dealing with more than one pathology in a single case. Thank you very much for your attention. I hope this was helpful.